We're not going to talk now research. We're going to talk about common problems and management of common problems, okay? And sleep came up as your first, most prioritized concern of all the issues our kids face. And I can tell you that it actually reflects what the literature says. So about 2/3 of kids who have neurodevelopmental disorders, irrespectively of which disorder they will have a significant sleep issue at some time in their lifetime. And it does actually impair function for the kid, because you can imagine, the moms in the room who remember what it was like to have the baby the first few months of life, you know what your day looks like the next day and how you feel if you haven't spent the night sleeping. So sleep deprivation produces behavioral disturbance, but it's also bad for the life and the quality of life of the whole family. So when our kids don't sleep, their parents don't sleep, and sometimes their siblings don't sleep. So we get these whole families who are sleep deprived. So I'm not going to give you tons of research. I'm just going to talk about the basics of what the sleep differences are and the basics of sleep management in kids with neurodevelopmental disorders. So I'm going to give you a case. And by the way, a lot of these cases and some of these slides were given to me by Dr. Shelly Weiss, who was supposed to be the speaker today, but found herself having been double booked. So I took over the job. So Peter happens to be a 5-year-old boy with autism, and he has insomnia. He drinks Coca-Cola with dinner and recently got a Wii video game system for his birthday, which he plays after dinner. His bedtime is at 8 o'clock. He has difficulty initiating sleep and will often recite segments from his favorite video for 1 to 2 hours before falling asleep. Other days he will cry and scream when put to bed. His parents are exhausted and his mother has started sleeping with him so that the family can sleep. Sounds familiar at all? Oh yeah, okay. All right, so why does Peter have trouble falling asleep and sleeping through the night? First thing, I want you to yell some answers out. Coca-Cola, yes. Weed, yes. So he has exposure to things that are stimulating to the brain. Caffeine obviously is a well-known stimulant for the brain, and we think of coffee, but Coke actually has per gram more caffeine in it than coffee. So we're actually caffeinated when we drink Coca-Cola. And the second thing is the screen issue, right? So the screens that we use for TV and for video games have a spectrum of light that actually suppresses our natural melatonin. Melatonin is a hormone that our brain uses normally to tell us that it's time to go to bed, that makes us sleepy. And so when we have exposure to those screens before bedtime, we naturally suppress melatonin. So we wake ourselves up. But I want to basically put forward a system by which you can think about when you approach your child's sleep problem. So you can think about 4 different categories of problems that contribute to sleep difficulties. One is a child can have an actual sleep disorder, and we can talk about that last. They are common, they're not as rare as people think, and they need to be investigated. Other categories have to do with biological medical problems that have nothing to do with sleep but end up disturbing sleep, and we'll talk about those. Behavioral issues and other psychiatric or mental health comorbidity, and we'll talk about those. And then the medications we give our kids for other reasons mess up their sleep, and we need to be thinking about that. So let's talk about biological. So we know that there may be certain neurotransmitter abnormalities across these neurodevelopmental disorders. So these are the chemicals in your brain that are important for messages to go from neuron to neuron and from one place in the brain to another. So we know that there are some differences in neurotransmitters in some of these neurodevelopmental disorders that do have effects on melatonin. Again, melatonin is our natural hormone that's important for falling asleep. And so we expect that some of the kids with neurodevelopmental disorders have differences in the melatonin they produce. There is a little bit of data to suggest that's the case. And we also know that the circadian rhythm, this sleep-to-wake cycle that we're all experiencing, is disturbed in a good % of kids with neurodevelopmental disorders. Again, there is a little bit of lack of clarity on that, because melatonin, a change in melatonin, a difference in melatonin would produce a circadian sleep disorder. But also we have certain genes that have come up from the whole genome sequencing studies that are circadian clock genes. So there may be a genetic predisposition to having a sleep-wake abnormality. There is also other reasons why your melatonin would be low, in which case, or have a typical secretion, in which case your sleep would be disturbed. Medical things are unfortunately very common things we all forget about, right? So having reflux is one of the most common reasons why kids have a sleep maintenance problem. So untreated reflux will produce a sleep disturbance. Constipation produces a sleep disturbance. Vomiting, obviously, and rumination for kids for parents in the room that have kids with intellectual disability. You know that some of these kids actually bring up food up in their mouth and then bring it down, up and down again, and they do it multiple times during the night, and that has significant effects on sleep quality. And then we have issues related to seizures. So obviously kids who have seizures during sleep get disturbance of their sleep. So the reason I'm putting those up is when you talk to your pediatrician or your family doctor and you have a sleep issue, yes, we think about the primary sleep disorders that have to do with melatonin and genes and so on, but we also need to think of common pediatric problems that our kids experience that actually interfere with sleep, and they're actually treatable, right? There's no reason why we wouldn't treat the constipation and the reflux and so on. There is a little bit of a red herring that I'm going to put up there. So kids who have very low iron stores have also been reported to have sleep disturbance. And so pediatricians don't routinely check for iron stores. This is not your circulating iron. This is how much stored you have in your body. It's called a test called ferritin. And so it is important, it's probably important at this stage, given the data that we have, that all kids who have a sleep disturbance when they go to their pediatrician or family doctor get their iron stores checked, because again, this is an easy fix. We can actually replenish the iron stores. Now, psychiatric and behavioral issues. So under psychiatric, I put other diagnoses per se. So, anxiety, mania, depression, actually lead to a sleep disturbance, and for kids who have those comorbid conditions, they need to be treated for a variety of reasons, including the integrity of their sleep. But behavioral stuff is the common stuff that all of our kids have, right? So emotional regulation, difficulty with transitions, understanding parental expectations around sleep. These are common problems that are associated with sleep disorders, and the little piece of interesting kind of trivia that I'll give you about this is that even if your child had a sleep study and had a documented sleep disorder on the study, 2/3 of those kids would be responding to manipulations, behavioral manipulations that treat those kinds of problems and would not need medication. So even if you had a primary sleep disorder picked up by a sleep study, if you had adequate behavioral support to deal with regulation, transitions, and setting clear expectations, 2/3 of the time you'd be successful. And I'll get back to the details of that. So the last category is medications. And I just don't have good news for you there. Pretty much any psychotropic medication we use has an effect on sleep. And occasionally you get hypersomnia, so kids getting very sleepy, but even the drugs that cause sedations that you would assume should be okay for your sleep sometimes produce a sleep disturbance because they change the sleep architecture, the way the biology of the sleep during the night. So I have SSRIs there, I have stimulants, and I have anticonvulsants, and we don't usually put atypical antipsychotics in that category because they are sedating, but the truth is they may affect the sleep architecture. So it is what it is. Sometimes we need those medications for other purposes. I'll get you in a second. Yeah.
What's the AD?
Antiepileptic medications for kids who have seizures. So we do this, right? The medications actually do produce a sleep disturbance. There are some sleep disorders that are more common in our kids than others. So the ones that you need to think about are obstructive sleep apnea. So these are the kids who are snoring and have apnea during sleep. Snoring is not a normal thing, despite what some dads think. And snoring in kids actually is usually a sign that you need a specialized evaluation, because very large tonsils or very large adenoids can interfere with sleep architecture. Parasomnias are different types of sleep disorders that alter the way the sleep architecture works. And then restless leg syndrome is something that we think is underdiagnosed in our kids because they are fidgety and they have abnormal movements before sleep to begin with often. But it's important to diagnose because the treatment for restless leg is very different than other treatments that we give for sleep disorders. Okay, most common presentations of sleep disorders in kids with neurodevelopmental disorders when we actually document them in a sleep study. So long time to fall asleep. This is everybody's pain. Most common complaint is that the kids just cannot fall asleep. It takes 1, 2, 3 hours to get the kids sleeping. Some kids have a preference for a delayed bedtime, which typically speaking is not the end of the world. But if you guys are exhausted and you need to go to bed and your child has a preference for a delayed time, it becomes a bit of a problem. We have bedtime resistance, and I'll talk about this in a sec. We have anxiety around sleep. Some kids are afraid to fall asleep. We have kids who have decreased sleep duration, and actually this is the one thing I'm not going to talk about because we have no solutions to it. There are some kids who will sleep just 5 hours and in fact seem to be rested the next day. Traditionally, this would not have been a problem. If it's good enough for them, it should not be considered a disorder, but it causes a disorder in everybody else in the family, which is the issue. Increased arousal and awakenings. These are the kids who are falling asleep but keep waking up during the night. And then we have a subgroup of kids who do this very early morning awake time. They're up at 4. So when they're up at 4, you're up at 4. The whole family is sleep disordered. Okay, so treatments, quickly. So first of all, we need to know what kind of sleep problem you have, right? So I think you should expect from your pediatrician and you should expect from your family doctor, but you guys are going to sit down, you're going to go through this list of potential causes of sleep problems, and you're going to figure out what are the relevant problems with your child, right? Just giving everybody melatonin is not a solution. And also for kids who can develop a skill, because there's a skill in falling asleep, just giving melatonin does not provide the skill, right? So it's important that you sit with your pediatrician and your family doctor and you go through all these categories to figure out which ones are most applicable to you. Optimizing sleep hygiene. So I'm going to be completely honest here with you because I think you're probably rolling your eyes now. It is true that optimizing sleep hygiene is the most important thing that you're going to do, and by that we mean a sleep routine that's reliable, that gets done the same way every time and all of that. The reason some of you are rolling your eyes is because you know all of this and it still doesn't work, right? And so I will be honest with you and I'll acknowledge the gap in our service system. So we have now randomized control data to suggest that giving the parents the information is not effective. So just giving you a flyer with all the stuff that you're supposed to do, you already know that. You've been on the internet, you've been trying it for years. Me telling you is not actually fixing your problem. What is actually extremely effective is giving you a sleep coach. And so we have nice data to say that if you have access to somebody that you're going to develop a plan with, you're going to try it the first night, it doesn't work, you call them the next morning, you tell them what happens, they tweak the plan, you try it the next night, you call the next morning, you give them information about what happened, they tweak the plan. That type of intervention is effective between 65 and 70% of the time. If you're asking me what part of our service sector will pay for a sleep coach, yeah. So it is where the data is. I can tell you it's effective. There are certain places where you can get it. So for example, if you're a Holland Blue Review client, you can get access to our fabulous nurse Beta, who is a sleep coach. There is some training that we have done to the TPAS program for those little ones that have autism in the Toronto area, so that the behavioral therapists know the curriculum, but basically our system will not pay for this. Behavioral interventions are important. You can access them through the regular ways that you access behavioral interventions, depending on the disorder that your child has. You know that you have more or less access. And then last resort is your medications. I'm going to actually skip some slides and go a bit faster because I know that it's lunchtime, but I want to give you some critical pieces. So first of all, there is tons and tons of books on parental education, and again, I acknowledge that these books are really good and you should buy some of these materials, but I also acknowledge that our randomized control trial showed that just for us to tell you what's right is not what changes the outcomes in the kids. So this is the summary of the handbook or the information you would get from us if you were part of our program. We would say first provide a comfortable, once you have figured out the issues, and this is not, let's say, a severe anxiety disorder or a severe medical issue or seizures that are interrupting the sleep, and we need to get down to the behavior of sleep, these are the basics that we would recommend. You provide a comfortable sleep environment. I will show you an example of what we mean by that, okay? Because we don't all mean the same thing. Establish consistent bedtime routines. I know they're hard, they work. You have to do it exactly the same way every night, whether it's Saturday or Sunday or a school day, whether you're on vacation or not on vacation. You have to do it the same way every time. Teach your child to fall asleep alone. I will show you a slide in a second to show you how important this is. So this routine that we get into where the mom goes into the room and sleeps with the child so the rest of the family can sleep means that you will never resolve your problem. And I want to show you the biology of why this is important. Avoid naps, easier said than done, but if you can avoid naps, and consider daytime activities that promote sleep at night. So who's going to tell me which room is a better sleep environment? I know this is pretty, but this is an appropriate sleep environment for a kid with a sleep difficulty. Okay? It's too arousing. There's too much stimulation. There are too many things to do. It doesn't say sleep time. It says my personal time to do the things I love. Right? So, boring, plain rooms for sleeping is comfortable sleep space. Okay, if you have to check on your child, you cannot keep going in and out of the room. So consider using technologies or modalities that allow you to check on your child without you physically having to go in and visit. You can hear me? Okay. So you can use a camera, you can use these little, I don't know what they're called. You can use your iPhone, there are all kinds of devices. But if you can avoid going in and out of the room, please try to do that. Okay, we talked about the routine. I'm going to give you you know how to do a routine, but I'm going to ask you to think about not copying the routines that you see in place for typically developing kids, and think the specific needs of your child. So a typical routine for a typically developing kid that you will see in most books includes something like bath time, for example. Lots of our kids find bath time stimulating, and it does not work as a sleep routine. So when you develop your sleep routine, make sure that it is activities that your child finds relaxing. Use a timer when you do a sleep routine. So a sleep routine that lasts 2 hours is not a sleep routine, and it does not solve your problem, right? So you use a timer, you put 15 minutes on it, you put whatever you decide that you're going to put on, and you're going to have to stick with that timing for the sleep routine. And then you have to use a visual schedule. And I have given you examples of two. One is for kids who clearly read and use a lot of language and would be a bit offended by seeing seeing pictures. And so a typical thing could be something like put on your pajamas, use your bathroom, wash your hands, brush your teeth, get a drink, read a book, get in bed and go to sleep. Every time you complete one of these stages, they get to check it, and it gets to be complete, and they get to move to the next one. And once you get to the last one, this is not negotiation time, right? And you can consider adding token economies around to those types of schedules. So if they actually get it right, they get a sticker, they get something. When they collect 4 or 5 stickers, they get a big reward. You can use your standard behavioral techniques for using your visual routines. Now, for kids who don't have a lot of language, you can use visuals, and if some of you do not know where to get visuals, just come to me on the break and I'll tell you a few resources where you can create these things. The other thing we say from a practical point of view is use a Velcro and stick in the cards with all the visuals so that you can change the routine as your child grows and they can become more independent. Regular schedule, I mean, it is that. If you have a different schedule for the weekend and a different schedule for vacation, you don't have a regular schedule. I want to show you this just to tell you why it's important that your child learns to sleep alone, okay? This is normal sleep. This is not abnormal sleep. Sleep has 4 stages, 5 stages. So we go from our REM sleep, which is when we dream, which is the least deep sleep, all the way down to stage 4, which is very deep sleep. During the night, normally, this is typically developing a kid for a typically developing kid. What you do is you fluctuate your level of how deep you're sleeping, right? So normally, you'll pretty fast get into deep sleep, and then at least 4 times during the night, you're going to bring yourself up to very, very light sleep. And a lot of us normally, forget pathology, normally we wake up when we're at this top part of how light the sleep is, when we're in a REM sleep. Most of us don't know that we have woken up because we put ourselves straight back to sleep ourselves. But you can imagine that if that happens to a child that can never fall asleep on their own, every time they get up here, and you don't even have a sleep disorder, you think you have a sleep disorder, but you don't, is the whole family is up trying to get him back to sleep. Does that make sense? So sometimes it looks like you have a sleep disorder, but really what you have for these kids who have multiple awakenings during the night is an inability to fall asleep on your own. So one of the most important things you can do from a sleep hygiene point of view in the long run is to teach your child how to sleep on their own. You're going to tell me how to do it. You're going to ask me how to do it. And I'm just going to get to the place where, actually, forget this, because we're out of time. I'll tell you how to do it. So you can do it 2 ways. You can do it the old-fashioned way, which is you let your child cry and cry and cry until they fall asleep. And it's 3 nights of hell, and then it's supposed to work better. You can still do that. We can tell you from our experience in clinic that you have told us that this is not an acceptable solution for most of you. And we hear you. So if you can do it, go for it, because it actually works. So if you can actually let them get distressed for 72 hours, 3 nights in a row, it's a very small % of kids who will not be falling asleep the next day on their own. But if you can do it, and we get it, there is something called a graduated extinction. So you basically pick how long you're going to let them cry for the first night. It could be 2 minutes, and then you walk in. You soothe them, you leave the room. The next time you leave them for 4 minutes, 6 minutes, 8 minutes. Apparently 8 minutes is a magic number. So once you get to 8 minutes, you let them cry for 8 minutes, and then you go in and soothe them. It takes longer, but apparently this technique works. It's called the graduated extinction. The other thing you can do is you can use the rocker chair method. How many people are familiar with the rocker chair method? So you get a rocker chair, you turn your back, you are in the room, but you turn your back to the kid, you start next to the bed, slowly over the following nights, you start moving your chair further and further and further away from bed until your chair is outside the door, right? All of these things take time, we know. But all I can tell you is that even if they have a true latency sleep disorder on a sleep study, these techniques work 2/3 of the time. So much for behavioral techniques. I want to tell you a little bit about melatonin because that's what most of you are going to get. The bedtime pass is something that some parents like to use for kids who have a little bit of language, even when they don't have language. Which is basically they're allowed 1 excuse out of bed, right? So they get a card, it's a bedtime pass, they can exchange it for a cuddle, for water, for something. They can only do it once a night, and if they don't use it that night, they get to get a reward, exchange it for a reward the next day. So it works for some kids, it doesn't work for all kids, but you can use bedtime passes, and we create social stories around the bedtime pass. We tell kids why it's important that they sleep, and they can tell a story about why it's important that they sleep. So last quick thing on medication. So there are no randomized controlled trials of most medications people use for sleep purposes in kids with neurodevelopmental disorders. I want you to know that. I want you to also know that the safety profile of most kids, of most medications used for sleep has not been tested in kids. So we do things that are reasonable, but I need you to know that these are not necessarily evidence-based treatments. The most data we have is from melatonin and melatonin products. And now we do have a systematic review that says that for kids with neurodevelopmental disorders who have a sleep onset problem, right? So having trouble falling asleep, because remember melatonin, all it does, it tells your brain it's time to fall asleep, that melatonin is effective. There are different ways of using melatonin. Some people will use it right before bedtime. Some people will use it 3 hours before, around dinner time, so our brain can be stimulated to produce its own melatonin. You can do either. The range of doses used are between 1 milligram and 10 milligrams. It's over the counter, you can use it. But again, remember melatonin is a medication. It's not going to teach them any skill. There is skill to falling asleep, and we still want them to be able to master the skill of falling asleep. You can use antihistamines like Benadryl. Body gets used to them very, very fast. So if you're going to use them only when you travel or you have a one-off night. If you use them every night, within a week, they become useless. And then there is the rest of the class, and I cannot make a recommendation for the rest of the class, although I have prescribed the rest of the class. So we need to be honest about that, right? So because we lack evidence, with your pediatrician, with your physician, occasionally you'll make the tough decisions of using a medication for sleep, even when we don't know the exact profile of that medication and its safety in this population. But we cannot, based on the evidence, make recommendations of use of those medications for the purposes of sleeping. How about I stop here and I take a few questions? Yes?
Can you speak to these magnesium in relation to sleep?
Yeah, so magnesium is getting a bit of popularity for sleep. You should know it doesn't have actually any effect on sleep per se, but it's a muscle relaxant. Right? So that's why people use magnesium for kids who have very high arousal levels and they're constantly tense. Magnesium is a muscle relaxant, and so you can use it as a supplement within the safety range that's on the bottle, but it doesn't actually affect your sleep. So it's interesting, the data is more for fragmented sleep, which means that there are kids who are waking up multiple times or waking up early. So that is the group that seems to be the most at risk for low iron stores. I'm not sure, I won't lie to you, we don't have thousands and thousands of kids to give you the exact numbers of the kids who have an initiation problem, but typically initiation problem is not an iron problem.